You're about to hear something all new to the world of aesthetic medicine. Five of the country's most credentialed surgeons, each at the top of their specialty, having the honest conversations that shape exceptional results. This is where surgical expertise meets collaborative excellence. This is Aesthetic Authority.
Hey, Dr. Quatela. So I want to talk about rhinoplasty today. Rhinoplasty is very different, than the aging face world in a lot of ways, and maybe we can get into that. But the thing that I think about rhinoplasty as a young surgeon, and as you know, because you're my mentor and I talk to you a lot about this, is that it's super, super common, but super, super complex. And I think that when I started, it was the thing that intimidated me the most as a surgeon. And I remember talking to you many times about, I'm nervous about this or about that, nervous to take on certain cases. And I think I'm well over that. And now rhinoplasty just excites me, and it's just such a rewarding procedure. But how did you feel about it when you started?
I think rhinoplasty was as intimidating to me as it was to you. It's one of those things that is so complex, and sometimes you don't know how complex it is until you get into it.
Right.
I can't tell you how many times I've looked at a nose and thought, "Oh, this is gonna be easy," and then 2 hours later, it wasn't easy,
Absolutely.
And I think that's what makes it challenging, that's what makes it fun, and I think that's what kinda gets you, kinda wrapped up in it.
Absolutely.
Yeah.
Yeah, I think so you're right. It is really complex because you don't know often what you're getting into until you open up the hood, so to speak. But it's also just such a vulnerable spot on the face. It is literally the centerpiece of a face, and it feels totally exposed. It's not something you can cover up with clothing. Other than in the mask era of COVID, there really weren't very many natural ways to cover up your nose. So if anything looked off, if there was any sort of scarring that didn't look quite right or swelling that didn't look quite right, it was just right out there in the middle of everything for patients to, or for, excuse me, for people to see on the patient. And I think patients are super aware of that. So that's why they're intimidated on their side. But then also as surgeons, we're sort of aware of that because we feel like we don't have a good fallback position, so to speak. Like it has to be right, you know?
I agree. I I think when I think about the single most or the biggest aesthetic change that I can make in a patient, it's the nose
Yeah.
in the face. It's clearly, and it's funny because you're not making big changes technically, but the changes that result are sort of monumental. And the other thing is that, it's not an operation that's in isolation because all people's faces aren't the same, and there's different facial proportions, where their hairline is. Do they have a chin? Don't they have a chin? Do they want to have their chin augmented? All those really impact, how you view nasal length, nasal rotation, nasal projection.
Right.
Those are all really important features in terms of how the outcomes come out. And so I just find that, when you're talking about changing the nose, it's much more impactful than chin implant or cheek implant or just
Right.
about anything else we do to the face.
Yeah. Yeah, it was actually like I think it was a couple years into practice before I really equated or really like realized how different the operations were. And I think one of the biggest things, it's just sort of psychological, but it's sort of just technical too, is it's fundamentally not an aging face procedure. It's different. It's changing the structural components of the face, and changing the facial harmony in a way that the patient sort of never had, as opposed to maybe restoring a jawline that the patient did used to have,
Right.
just turning back the clock. And I think that that is another thing that is really, really important for us surgeons to realize, but maybe more important for patients to realize is that when you're thinking about undergoing a rhinoplasty, you have to really think about it like changing your look fundamentally as opposed to just turning back the clock to what you used to look like.
Right.
Yeah.
So Alex, when I think about rhinoplasty, I think about how complicated a procedure this is, and there's so many different factors that the patients don't consider, and we have to sort of educate them about it. But for example, the skin envelope. The skin envelope. I often will say, you either have a down blanket or you have a bedroom sheet. And if you have a bedroom sheet, then all the imperfections show through. If you have a down blanket, all the nice things that we do to improve the structure don't show through.
Right.
And so, there's that ideal skin. There's cartilage. All cartilage is not the same. Some is stiff, some is soft.
Mhm.
Some has good structural integrity and others does not. And so we sometimes can look at a nose, we can look at it topographically, we can look at it from the standpoint of aesthetics, but until we get into it, you can't feel the insides. We can't some bone is real dense and so therefore it's hard to manipulate it. And so those things that are different in every patient, I think, is what makes the operation complex and also challenging, but also interesting and very
Right.
exciting.
Absolutely.
Yeah.
And all those things play into the exact sort of 3D structure that you're going to end up with. And I think you always taught us that like millimeters matter, in rhinoplasty in a way that they don't matter nearly as much in facelift surgery. You can rotate someone too much, meaning the nasal tip looks too lifted. If it's a millimeter too high, it can often look, overdone or, unnatural. And again, that's why, we go to such painstaking efforts to do everything as perfectly as we can in the operating room. And we're constantly looking at it, reassessing. Okay, now we need to make this manipulation. Okay, what's that look like? Reassessing. Now we need to make this manipulation. And it's very much um, kind of tweak it as you go sort of operation, as opposed to let me go through the steps and it's done. You're constantly having to reevaluate the on table result because a little millimeter here matters. And I've found that because it is this really complex 3D structure, you might make the millimeter manipulation you want to make on one side, and then but it's not until you step back and look like, oh shoot, when I made that manipulation, that affected this other side in a way I wasn't anticipating. Now I need to go manipulate that. And it's this constant back and forth till you get to the final product. Um,
I I liken it to dominoes
yeah. Yeah.
because when you make one maneuver, it affects your next maneuver. And it almost if you do it in a standard sequence, it almost creates the next step,
Mhm.
you know.
Yeah. And so another thing that is really, I think, difficult for patients to understand until they go through it is how long it really takes for results to truly be final. We quote a year. I think that's kind of the standard practice, the standard industry um, practice to say, oh, it takes a year to see your final results. But I don't know. I've noticed this trend. I don't know what you think, Dr. Q, but I think the older the surgeon, the longer they think the results take to be final because you've seen your patients for longer. So if you ask a surgeon that's been in practice for 30 years, they'll say, "Oh, I think rhinoplasty takes 30 years to see the final results sometimes." And if you've been in practice for 5 years, you think, "Oh, I think it takes 4 to 5 years to see the final results." And so it takes a long time, I guess, is the moral of the story, and every patient's different. And it also matters, I think, whether it's a revision case or a primary case, and that skin envelope that you talked about is very important.
I think that every nose we do looks better right out of the box. When
Absolutely.
the cast comes off, there's always like some emotion, some tears,
Hmm.
and I think it looks better right away. But I have some patients who sometimes are 3 or 4 years out, and they're still coming in for a little steroid injection to help with swelling and skin thickness. And so, you have to paint that picture for the patient as well.
Right. Absolutely.
So, Alex, when I think about when I started doing rhinoplasty, and then I think about where we are today, I see 3 distinct, eras or segments.
Okay.
Reduction rhinoplasty was everything in the '60s, '70s, and even '80s, and it was a matter of you made the nose smaller by taking things out, and not necessarily putting anything back in,
Mhm.
and so there you had We talk about how long it takes a result to occur. That's where there's a lifetime of change because you've destructured the nose, and then it just takes time for that to sort of show its true colors. We sort of then went to structural rhinoplasty, and that was more of like began in the 80s, but it was 90s and still to present. And that was an effort that actually created more predictability in rhinoplasty.
Mhm.
Whereas the first one took forever to see a final result, this one here, I think, you would see a final result anywhere from a year to 5 years, and it wouldn't change beyond that. It's very interesting. I see patients now 30 years later, and with structural rhinoplasty, it's the same nose.
Mhm.
But then, that was the concept of, preserving, adding, creating structure. And then we evolved into like another step of preservation. I mean, it's the antithesis of reduction rhinoplasty,
Right.
And I think here we're looking at what are the elements of the nose that we really like and we want to keep. And specifically, we'll talk a little bit more about this, but the dorsal elements of the dorsal lines, preservation rhinoplasty, preserves that. So
Right.
I think the evolution, from reduction to adding to preserving, preserving makes a lot of sense,
Sure.
you know.
Absolutely. Yeah, I've had fun thinking about this because, when I started learning rhinoplasty, it was in the midst of learning all sorts of other otolaryngology, procedures, sinus surgery, head and neck surgery. And when you're a resident training, you often don't really get to sit and reflect on the historical context of the stuff you're doing. You're just kind of, you show up, you do the best you can. And so to me, structural rhinoplasty, that second era that you mentioned, was sort of, that was just how you did it. I didn't at the time have that context of knowing like, well, we used to do these reductive type rhinoplasties, and that's how we ended up with these Bossa deformities, or the Michael Jackson sort of like over operated look. I didn't get that, just because it just was sort of out of sight, out of mind. And it wasn't until started focusing more on rhinoplasty, I think it was when I was training with you, that was kind of doing a deeper dive into the history of rhinoplasty surgery. And then you recognize, oh, this is actually why we do it this way, is because we're avoiding those mistakes of old. And that was all the structural rhinoplasty stuff. So you're adding cartilage to make sure that the nose is maybe even stronger, when after surgery than it was before surgery, so that those results are more predictable, as you said. This preservation thing is really super exciting. We've all kind of got this advanced training in it, and I think that it's certainly not for every patient. Not every patient is a great preservation rhinoplasty candidate. But for those that are, it's a really, really exciting new way of doing the surgery that um, and that does just what it says it does. It preserves a lot of natural aesthetic lines. It preserves in a lot of ways the skin envelope integrity. It can preserve some of the dorsal aesthetic lines, as I mentioned, and I think when done well, can lead to a faster recovery and even more predictable results because a lot of the structural integrity is maintained.
What is preservation rhinoplasty?
It's a great question. Um, so what an analogy I use with patients that I think works pretty well is, and this also speaks to why not every patient's a great candidate for it. But let's say you have a dorsal hump, so the kind of classic, hook-looking nose, and you don't like that, and you want to bring that down. As you know, Dr. Quatela, the sort of standard way to do that in the structural rhinoplasty world or in the reductive world would be to open the skin of the nose and file it down, just literally sort of shave it down. And the analogy I make is to like the roof of a house. So if you think of the dorsum of your nose being roughly shaped like the roof of a house, if you liked the roof, you liked the slate roof and the chimney and all the contours, but you just wanted it to be lower, you'd really set yourself back by shaving off the top of the roof because you're creating all these new aesthetic changes and lines and irregularities that now you've got to rebuild and smooth over and make different. But wouldn't it be better to maybe take out the pillars of the house below it and just drop everything down? And that way the roof doesn't fundamentally change, but it just drops into a lower position. That is the sort of analogy that is preservation rhinoplasty. So you're dropping the roof of the house without changing the structural integrity of the house. And so you're preserving all of that and making everything a lot more predictable. So one of the things, Dr. Q, as I mentioned at the start of this podcast, is I was super intimidated by rhinoplasty starting out. But one beautiful thing about our practice here is the sort of collaborative nature of our work. It's not every case by any means, but we're all always here, and we always avail ourselves to one another. And I know Dr. Lee has been in the operating room with me several times. You've obviously been in the operating room with me several times, and vice versa. And I think it just, especially for a complex case, it just allows us to bounce ideas off of one another. And in my case, continue to still be mentored by you because you've kind of seen everything. And it's just allowed for, I think, a speed up in my confidence, if you will, because knowing that I have the support from these other great surgeons right here under the same roof. And it's really fun to still be able to kind of bounce ideas off one another.
I think it's great to have you and Dr. Lee here for a lot of reasons. I mean, sometimes an outcome isn't exactly what a patient thought it was going to be, and it's always nice to sometimes not only bounce the result off of you and Dr. Lee, but also maybe have you see the patient. And that's always comforting to know that, I worked in the university setting, in the late 80s when I started, and there was no forum.
Yeah.
There wasn't anyone to turn to just say, "What do you think about this?" Or, "Should I do this patient?" Or whatever,
Yeah.
and I know we've had those conversations,
Oh, absolutely.
"I just did this consultation, and I'm not sure I can make this patient happy. Would you
Yeah.
take a look at them?"
Yeah.
We've done that before, so
Yeah.
I think there's tremendous value, in having partners who we can collaborate with and,
Yeah.
change sometimes change how we think about things, which
Right.
is great.
Yeah.
I love that you guys have adopted preservation rhinoplasty. I think that's great. I've told you this before. I get bored and we change
Yeah.
sometimes just
Right.
for the sake of change,
Right.
you know?
Right.
It's not like I made bad rhinoplasties for 30 years.
Right. Right. So speaking of change, we do see a number of revisions come through our office, and actually, it reminds me of a patient I saw very early on. It could have been within the first maybe couple of months of starting here. Is a really complex revision case. It may have been a third or fourth revision. I don't remember the exact number, but this is the kind of the perfect example of someone that I saw. I think conceptually, I sort of knew what I thought needed to be done, but I was really intimidated by it. And I actually referred that patient to you. And we talked about it. You ended up doing the surgery, and I happen to know, because I spoke to Brooke about it recently, that patient is doing fantastic and is very happy with his outcome. Um, and now it's funny, I look back at that and now I have the confidence and I'm like, I would never refer that. I want that case back, but at the time I just didn't have that confidence. And, but the beautiful thing about this place is we were still able to deliver a really good result. And I think he's coming back for a hair transplant now or something like that, because he's just really happy. But revision rhinoplasty is sort of its own animal. And that was kind of the point of that story is, it often sort of, what was a normal, maybe cookie cutter, go through the steps and do the right thing, primary sort of surgery becomes completely different in a revision rhinoplasty case that I do think is fundamentally different than a revision facelift case or a revision eyebrow lift case. It's just a different surgery. And so you have to go into it with an entirely different set of tools in your armamentarium.
Yeah.
Yeah.
There is, There's the issue of scar tissue that you deal with. There's the issue that the pieces, parts that you need to repair the nose have already been used once or twice. And so you're looking for alternate sources of cartilage. We sometimes go to the ear, sometimes we'll go to rib cartilage in the chest. Um, but all bets are off. The normal anatomy might be removed, and
Right.
so you may not find the cartilage in the nose that you expect to find. And then there's always most revision rhinoplasties have functional issues as well.
Oh yeah.
They can't breathe. There's internal nasal valves which are collapsed. The septum can be persistently deviated. So all those things really, really complicate things. And we allot more time, we allot more thought. And I think we try to present a more realistic picture to patients because the outcomes are not quite as predictable as they are with primary rhinoplasty.
Right. Absolutely.
Yeah.
Yeah, I think that you mentioned early on that with rhinoplasty, you sometimes don't know what you're going to get until you open up the hood, and I think that is pretty much the case 100% of the time in a revision. I think all surgeons, I know I do this, I sort of visualize the case for maybe several days, but certainly the night before surgery, I'm thinking about, okay, I'm going to do this and then I'm going to do that. You're kind of thinking about the steps, and I'm going to put this suture in, and then the cartilage is going to move like that. And then I'm going to make this cut and it's going to move like that. And invariably in a revision rhinoplasty case, you do all those steps and it doesn't do what you thought it was going to do. You tie the suture and it doesn't, twist the way you thought it was going to do, or you make the cut, but the cartilage is too firm or it's ossified, so you can't cut it. So now you got to think of something different. And so it's just like I said, a totally different animal. Well, we're talking about revision rhinoplasty, and I think revisions in particular, but all rhinoplasty, because of its complexity, I think that it is probably the sort of seminal procedure that highlights what we do here. I think, Dr. Quatela, is that this collaborative nature of our work. I know I can think of some instances in the revision world where there's just little techniques here and there. I mean, there's hundreds of described manipulations you can do in rhinoplasty. I'm sure you've done a lot more than me, but I'm sure there's plenty that even you haven't done in your long career. And so what I find in revision cases is that I'm thinking about some technique that I'm like, gosh, they need this type of graft, or this type of composite graft, or this type of manipulation, and I haven't done that exact thing. I've done a variation of it. So let me talk to Dr. Lee. Let me talk to Dr. Quatela. I bet they've done something like that. And so I've really enjoyed like coming together, looking at a nose and saying, oh yeah, I've had a patient like this, and I did this type of grafting and it worked really well, or some variation on that theme. And the other thing I think about too, it's sort of a side piece of this that we haven't really talked about, but we do a lot of nasal reconstruction in the skin cancer world. And I know you in particular have done a number of rhinoplasties on patients that you had previously done skin cancer reconstruction on. So we sort of have this more comprehensive thought about the nose and the way it comes together, because we've put the skin and the structure back together, put Humpty Dumpty back together, so to speak, and then made cosmetic manipulations on top of that. So we've come at it from all these different angles, and it just gives a different level of expertise and appreciation, I think.
Yeah. And, it, I always say the teacher becomes the pupil.
Yeah.
And it's always fun because we go to different meetings, we do, we read different things and we have different thoughts. And it's always fun to put all our minds together. And it's just like, preservation rhinoplasty now. This, honestly, it isn't new. It started in the 30s, with
Right.
coddle and a letdown procedure, and but now, it's being popularized and actually, has great advantages. But just on this one topic where we've shared our ideas and shared our thoughts and said, "Hey, we have to do this, and we have to," and that's been fun. It's been fun for me to watch you guys,
Oh, absolutely.
dive into something, relatively invented,
Yeah.
but new, and it's fun to watch the great results that come of that.
Yep.
And I think on this particular topic, we've had a great exchange.
Yeah.
So there's a distinct advantage to having three facial plastic surgeons. And I can tell you from experience, when it was just me, and that night when I was reading about the case the night before and not having anybody to bounce it off of, that's not fun.
I think that across the industry, rhinoplasty is certainly considered one of the most complex things that a plastic surgeon can undertake, but it is also one of the most rewarding, and it is one of the most life-changing for patients. Again, as I alluded to earlier, it's not fundamentally a aging face surgeries. You're changing the structure of your face, and that is creating a more harmonious face. And we've all seen it change our patients' lives. They angle differently in the way they take pictures. They have so much more confidence entering a room, and it can sort of brighten their face, brighten their eyes, even though you didn't do surgery on their eyes, because of the confidence that they now exude. So it's a wonderfully rewarding procedure for both patient and surgeon.
Yeah, I think that it's probably, from the patient standpoint of anything we do, probably one of the most important changes that they can make in their face, and they see it that way. I'm always amazed at um, how long people think about doing this operation before they actually do it. I just had a woman who uh, was 75, and this was a primary rhinoplasty. All her life, her husband didn't want her to change her nose. And then he was no longer in the picture, and she decided to do it. And it, you could just tell how important this was to her. I mean, this was hugely important, and it was like the most exciting day of her life, And I think that we don't realize sometimes, the whole backstory when we see a nose. Sometimes there's a whole trauma story to it, and so I just think that this operation is life changing, and I there's nothing better than taking that cast off and having that patient have tears of joy. It's just so fun.
Right. Right. Which is why it's so important for patients to not just sort of like look for the cheapest surgeon or make a quick decision, but they need to really think about it from a psychological perspective. Are they ready for surgery? And they need to find a surgeon that they really, really trust, that they trust their aesthetic, and that they trust that they're going to work with you and kind of not just have a good personal aesthetic, but also, do the right. We didn't get into our imaging enhancements and that sort of thing. We've talked about that on previous podcasts, but it really has to be a collaboration between you and your surgeon. That you don't want to just go in and get some cookie cutter nose. You want to make sure that they're going to achieve what you want as a patient. That is going to give you that confidence. That is going to give you that result that you want. And I think that we're really, really good at doing that here, because the only thing we care about is making a happy patient.
And I think the fact that I'm fellowship trained, you're fellowship trained, Dr. Lee's fellowship trained, uh, speaks volumes
Right.
that we spent additional training in rhinoplasty beyond what we were trained to do during residency.
Right.
And it adds a whole nother dimension of expertise that doesn't come in any other way.
Right. I agree. And frankly, Dr. Quatela, that's why I wouldn't want to be anywhere else. So, love Lindsay House. Think we do great work, and thanks for chatting today.
Thank you.